Please. I'd like to welcome everybody to Pediatric Grand Rounds. I would remind you to please find this sheet with the QR code on the table in front of you and scan it with your phone. It'll send you to a link to register for Grand Rounds and record your attendance. This is really important for us in terms of both tracking interest and getting feedback in Grand Rounds, and also to provide meals and CME. So even if you're not claiming CME, it really helps if you can log in and help us track your attendance. And we appreciate you coming out. Today it's my pleasure to Cristian Quizhpi. Did I get it?
That's correct.
All right. Sorry, I always have trouble. So Cristian joined us. He went to undergrad at Vanderbilt University, taught science in high school in middle school for several years, and he's kind of continued that educational component of his career. He has numerous educational activities for both community and patients. He went on to med school at the Medical College of Georgia before joining us here at ETSU Pediatrics in residency, and he's going to a neonatology fellowship over at Wake Forest. So today he's going to talk about the importance of the microbiome in terms of the health of infants, and look forward to hearing his talk. Thank you.
Thank you, Dr. Dodd. So I am a third-year resident here. The title of my presentation is the gut microbiome and the premature infant. There's going to be an emphasis in certain parts about the premature infant, but overall it's a presentation on the neonatal gut microbiome just because of how vast the subject is. I don't want to just make it specific to the premature infant. My mentor was Dr. Kumar, who, even though he's on nights, helped me review this PowerPoint. He's hopefully sleepy right now, but I do want to thank him. This is the slide that says I have no disclosures, which I don't. I want to start off with a question. It's a question I created based on the information I'm going to present to you, and hopefully by the end we'll be able to get the right answer. So the question is, a patient is born at 28 weeks gestation, is premature, with a birth weight of 1830 grams via vaginal delivery, induced due to HELP syndrome and non-reassuring fetal heart tones. He was transferred to the NICU, started on CPAP due to RDS. The mom is a PhD student in the School of Nursing, and also reports to have been spent the last 10 years in Uganda working at a children's hospital. But for the past year has been back in the US for her studies. The mother plans to pump and then will transition to exclusively breastfeeding after once the neonate is able. And the question is, which factor from the patient or the maternal history do you think will most affect the establishment of the neonatal microbiome? So the mode of delivery in terms of vaginal versus C-section, the patient's gestational age, the infant feeding mode, environmental/geographic history, or the maternal diet. So that's a question we will revisit at the end of the talk. All right, so let's talk about what made me think about this talk. So I first started when I started in the NICU here, started learning a little more about the neonatal microbiome, and as the years progressed, there's been a lot more research that I've been able to get a hold of and really dive into. One of the things that was intriguing to me was the holobiont concept, which is an idea that all of us in this room right now, are not just our genes that are passed down from both our parents, but also a combination of the genes that is in our, from the microorganisms in our gut. So for a mom, that's especially important because the genes that she passes on to whom she reproduces is also a passage of the genes from the symbiotic organism. So that's what the whole-genome concept is, where we're not just our moms aren't just passing on the genes within our own DNA, within our own cells, but also the genes that are in the microorganisms that she passes off through the birthing process. And then we'll look a little more about that. The mom continues to actually model the genes after the birthing process, and we'll talk about that throughout the other parts of the presentation. So the human body harbors about a trillion or more cells within our gut that are bacterial, and to be honest, there's not a strict consensus as to how much of the genome, our total genome, that consists of, but it's anywhere from half of our holobio or our hologenome consists of bacterial DNA to about a third, so it's a lot. So the neonatal microbiome, one second. It's the highest density again is in the stomach, or in the gut, not stomach, in the colon really. But there are other parts of the body that also get colonized, and we'll talk about that in the next slide. But what are some of the critical roles that the human gut microbiota exerts? Some of these include the breakdown of food substances that allow us to have access to certain nutrients that we otherwise wouldn't have access to, the promoting of host cell differentiation. So it's important, especially early on in development of our different organ systems, such as our GI tract, our nervous system, our immunological system, and our endocrine system. So there's just a few of those that the gut microbiome helps develop. The promotion of host colonization, or the protection of host colonization from pathogens. And again, the microbiome that we have in our as neonates in our gut sets us up for, according to recent research, a large portion of our later on chronic conditions, and the stimulation and modulation of the immune system. So we'll talk about how our immune system also gets developed or matured through our neonatal microbiome. So really in our gut, there's over 1,000 bacteria that have been identified, and in any one of us, there's about 160 that are usually found within our gut, but there are over 1,000 bacteria that have been identified. So it's important to understand that when we talk about the neonatal microbiome, it's difficult to say that there is one specific type that's normal or abnormal, but there is, because of how many different species there are, but there are species that are more than others usually in the neonatal microbiome. So here's an example of where some of the places as neonates they get first colonized. These include the nares, the oral mucosa, the skin, and the GI tract. To look at this, first I want to point out that in each section that this graph highlights, first of all, there's different colors to it because it talks about the most common bacteria that are present. The other part is that there's 2 circles per location, and that just emphasizes that not only is the location important, but also as time passes by from delivery to postpartum, the bacteria present there also change. And then finally, in each part of the circles, or each part of the diagram, or each diagram, there is different sections to it, and that just corresponds to the inter-individual variability. So one person can have a certain amount of a bacteria present in that same location. Another individual has a different amount. But again, the type or the common type of bacteria are the ones that are included in this diagram. The next thing to understand is the sterile womb paradigm. So this is an idea or dogma that's been established for a while that when neonates are born, the gut microbiome in there is blank. There is no bacteria that are present there prior to their birth, and the colonization of that space, specifically as well as other parts of them, is colonized after birth. And this is one of the reasons why the mode of delivery is so important, is because that's the first contact that these areas of colonization have with the outside world. The other part, though, there is a new body of evidence that's starting to show, or trying to suggest that colonization actually starts before birth. These studies include studies of the placenta, the amniotic fluid, and the meconium, but these aren't widely accepted yet. So what does it mean to have a normal gut? As I mentioned earlier, there are thousands of different bacteria that have been identified in the adult microbiome, and as the first diagram showed, there is a lot of instability in the microbiome, and it changes not just from the time of delivery till after, but from the individual to individual. So it's difficult to really talk about what a standard or healthy microbiome is for an infant, but there is a consensus that certain bacteria being present are more beneficial than others, and certain bacteria being present can have more consequences than others. Dysbiosis, though, is the idea that there is a change or a harmful effect on this microbiome or on the stability of this microbiome that in itself can have long-term consequences, especially if it happens earlier on before the establishment of a mature microbiome. This establishment of this complex microbiome is driven by both internal and external forces. And these forces we're going to discuss throughout the PowerPoint. So how do we study the microbiome? This is a area that's also changing, just like the idea of this sterile wound. There are more techniques or more recent innovative techniques that are being created or being used in research, but I want to talk about the one that's the gold standard currently in microbiome research that's using 16S ribosomal RNA gene profiling. So this is the same, this is the study of the same RNA of the proteins that are involved in the protein transcription translation. And then we'll talk about shotgun metagenomics in a second. So what happens is that, on the right is the 16 RNA gene profiling sequence. The reason this genome area is used is because it's highly conserved in bacteria with 9 variable regions. These 9 hypervariable regions are the ones that are used to identify the bacteria. So, but how you find these regions is by looking for the ones that are most conserved. And this specific genome in all bacteria is very, very highly conserved. So once you find these conserved regions, you can amplify them through PCR, and then you create OTUs, and those are used to identify what bacteria is more likely present in that sample that you obtained. This only identifies bacteria though and nothing else, and from there we can get an idea of, even in the same patient or the same population, as the patient gets older, you can continue doing these samplings and identifying the bacteria and then figure out how the microbiome changes over time. The problem with this though is that it doesn't tell us if when you obtain this information and you compare it to the databases that we have available, it doesn't tell, it's difficult to account for new bacteria that are present. You can't really identify that using this technique. Shotgun metagenomics, though, is a little different. What it does is it takes DNA fragments of the entire sample or wherever you obtain it from, and not only does it identify the bacteria, it identifies also possible products of the bacteria like metabolites, and can also analyze for function. The drawback with this, though, is first that it's expensive compared to the more conventional method, and it's not widely used yet. So establishment and composition of the microbiome. So these first 4 are things that can happen in normal microbiology that we look at when we learn microbiome, like in med school or in undergrad. Dispersal, local diversification, environmental selection, ecological drift. So with dispersal, there's a natural process that increases local diversity, and we talked about how we can think about the human body having all these different areas where bacteria first colonize, and in these areas is where the bacteria will get to, as well as other ones as we get older. Within these local areas, local diversification can occur, and that occurs through as the microbacteria adapt through mutations or recombination. And then environmental selection, it allows for the growth of certain microorganisms versus others. We'll talk about how maternal milk really emphasizes the growth of certain bacteria that have very protective and supportive effects in our gut versus other bacteria that don't. And then ecological drift, other bacteria that are low in abundance will eventually disappear, such as antibiotic sensitive strains, unless they gain an advantage through an outside factor. So I just wanted to include this slide one more time just to reemphasize how important the variability between individuals are. I know I talked about, I explained each slide, but it's important to emphasize how over time these areas will change. The bacteria that are present there will change completely from birth. At the end of about 1 year, most children have a microbiome, both in the gut and in these other locations. They are pretty similar. But that doesn't mean that because by 1 year or 2 years, the microbiome looks exactly the same, they're all going to have the same health outcomes, because the composition of these different microbiomes, especially the gut, early on is a really good indicator of what the possible future health outcomes can be. All right, so the first thing that can affect this gut microbiome that we're going to discuss is mode of delivery. We talk about vaginal versus C-section. With vaginal delivery, you're exposed to certain microbes, including lactobacillus, Prevotella. While in csection, you're more exposed, or you're more likely to be colonized by environmental microorganisms. I know that there is an effort to be as sterile as possible during deliveries, but a lot of times there are a lot of other things going on, and it's not always easy to do that. Plus, after the baby is born, depending on the baby's condition, they're exposed to a lot of different interventions very, very quickly. Patients born via C-section have a reduced complexity in their gut microbiome, and they're often colonized by organisms such as less often colonized by Bifidobacterium, which I'm going to stress later on in this topic as to why that's important, and Bacteroides. C-section has also been associated in numerous studies with asthma, increased risk for asthma, allergies, type 1 diabetes, and a higher incidence of obesity. Some of the bacteria that C-section neonates are more prone to having are proteobacteria, and are also found to be more frequently colonized by by bacteria such as Clostridium difficile. The gestational age is also another really important. Actually, it's the most important driver in the establishment of the premature gut microbiome. This helps answer our question in the beginning of the presentation. This is the most important factor of the ones I'm going to discuss. Preterm infants have a delayed gut colonization, and usually their microbiomes are less colonized with gut microbiomes that are of normal neonates that are important for their protection. So they have higher levels of things like Enterococcus, Enterobacteriaceae, which are opportunistic pathogenic organisms, and they also have some gram-negative bacteria. This slide looks a little busy, but the reason I didn't cut it down is because more than anything, I want you to look at a comparison of what's going on within the premature gut microbiome. So we start on the left on A, B, and C. It's looking at neonates born between weeks 24 and 25, and each Bifidobacterium is in the blue, and then Clostridium is in green. We won't focus too much on red. So what you're noted here is that over time, the Bifidobacterium or the Bacteroides will naturally gradually decrease, while Clostridium will gradually increase. This happens also in the normal neonatal gut. The next few rows, C, G, and J, show a very similar trend. Well, J and D and G show a similar trend. For D and E, those infants are born between 28 and 30 weeks, and then the ones in G and H are born between 30 and 32 weeks. So what's noted is that they have very similar trends, and specifically Clostridium by week 33 to 36 is when their highest level of Clostridia are noted to be colonized within the gut. So the gestational age matters, but by a certain gestational age after birth, the gut microbiome will have a very similar colonization in it. This emphasizes, but these patients will have vastly different health outcomes, even though what's colonized by them by their gestational age is pretty similar after a specific time. And this emphasizes how important the early colonization, or what's present early on for the neonatal microbiome, is important. So premature infants, in general, why are they more prone to adverse outcomes? So the first thing to understand is with a premature infant, their gut is obviously immature, their immune system is compromised, the respiratory and neurological issues are usually present, and they also have a extensive exposure to antibiotics and other drug treatments compared to infants that don't go to the NICU, or infants that are in the NICU but are placed there when they're born later on in gestation. They, aside from enduring these things like antibiotics and drug treatments, they also have long hospitalizations where they're usually put on artificial respirators and are fed artificially or parenterally. So all these factors interfere with the natural pattern of the microbiota acquisition and results in an abnormal composition of the microbiome. So it's important to know that even though their microbiome can eventually, as we saw in the very busy trend graph slides that I presented earlier, it's important to know that these small these changes that happen because of all these interventions have very profound impacts on their health later on. We'll talk about that later on in the presentation as well. Another important factor in gut microbe colonization is the mode of feeding. So here we'll talk about the importance or the protective factors of breastfeeding. So certain bacteria, specifically bifidobacteria, are noted to be more highly increased in breastfed infants. This type of bacteria specifically shows to have pro-microbacterial and antibacterial agents, this being the milk, and then because of those factors, it promotes the growth of certain bacteria. Specifically, one of the more important things in the bacteria are HMOs, or human milk oligosaccharides. And then when the infants of when the stools of breastfed infants was analyzed, it was shown to have higher levels of the bacteria we just mentioned, as well as lactobacilli, and then lower levels of potential pathogens and with those of their formula-fed counterparts. The other factor is environment versus geographic location. So with environment, one of the things I wanted to focus on, because I thought it was pretty interesting, was the presence of older siblings being associated with an increased gut microbial diversity and richness during early childhood compared to firstborn children or children that don't have any siblings or other children in the homes. One of the things that in the same Danish study that was noted is that having pets in the home actually didn't have that much of an impact compared to having other kids. And part of that could be because the kids that are present there usually don't share, they will share stuff with their siblings like bottles and food, but hopefully don't share with like their dogs and stuff. So it makes sense that pets don't have a huge impact. The next thing is geographic location. So it makes sense just thinking about that when we look at the microbiome of infants from different parts of our own country, cities versus rural, or looking at neonates from different countries itself, the US versus a rural part of like Bangladesh that I'm highlighting here, or parts of Africa, they're going to have microbiomes that are significantly different. For example, in the study looking at neonates between Bangladesh and the US, they were noted to have a gut microbiome that was a lot more prevalent with Provotella and depleted of Bacteroides compared to US children. Bacteroides specifically, like the bifidobacterium that's promoted by breast milk, does have protective factors as well. So here we're seeing that geographical location as well as local environment do play a factor in the gut microbiome. One of the questions, or one of the studies I found, was comparing these two, looking at the geography versus feeding mode. I thought this was super interesting. So it's difficult, I know this slide is a little difficult to look at. Part of it is because I took a picture of this in a presentation of our conference I recently went to, and I could not find this slide free. But it does highlight the colors, the more important thing. So you'll see that on the top there is a reference to infants that are breastfed in Malawi, which is in Africa. And then the top in the US section is divided into two parts. The top part is breast milk fed infants, and the bottom part is formula fed infants. One of the really striking things is that when you look at the breast milk fed infants, their gut microbiome is very, very similar to each other, even though we're comparing infants from Malawi to infants in the US. And then when you compare the infants specifically in the US between formula fed and breast milk fed, their gut microbiome is very different. So this just highlights how even though geography is a factor in here, how mode of feeding played a more important factor in the establishment of the gut microbiome, even though we're looking at populations that are very, very different from each other. And this looks at more, again, the bifidobacterium, which is the bacteria that, again, I'm going to talk about having all these protective factors to it. So let's talk a little bit about milk, human milk oligosaccharides. So human milk oligosaccharides is the third most prominent component in human breast milk. This is after lactose and lipids. There are a few different types of oligosaccharides, 5 specifically. So there's galactose, there's fructose, there's glucose, and NU5AC. So these 5 milk oligosaccharides, or these these 5 components make up of hundreds of different types of HMOs. And the important thing to know about this is that these HMOs will vary from mother to mother and will vary over time within the same mother. This is one of the advantages of breastfeeding versus formula feeding. Different companies of formula have tried to replicate breast milk because of all the advantages that I'm going to discuss shortly of HMOs, but it's difficult for them to replicate the extent that human breast milk has the HMO advantage, because obviously formula can only include a certain fixed amount of HMO types within their formula, and the variety and the change over time is a very important factor in benefiting from HMOs or from formula feeding. One of the things to know is HMOs, the way they work is, first of all, they're resistant to low pH. So once they get to the infant's stomach, they're not easily digested as well as other proteins are. They're also resistant to the pancreatic enzymes as well as brush border enzymes, and this allows them to get to the place where the bacteria are located, which is in the small intestine and the colon. And then their shape is also really important. We'll just talk about that in a second. The reason I put this picture of formula up there is just to show how prominent right in the middle of their label HMOs are in there, is because of the ongoing research of how important this factor in human breast milk is. So HMOs, which is the human milk prebiotic. So this is considered a natural prebiotic because it actively stimulates the growth of specific members of the gut microbiome. This is often bifidogenic, since it specifically enhances the growth of bifidobacteria. And then this is a specific Bifidobacterium longum subspecies. Infantalis is the lineage of the most prominent type of, within that subspecies of bacteria that is more prominently noted. The reason that's important is because HMOs can't be digested by any type of Bifidobacterium. Specifically, the subspecies infantis is able to digest HMOs for the human host to benefit from its products, and allow other bacteria to then break down, have access to the same oligosaccharide, and then further break down that compound, and then have more access to nutrients or growth of other protective bacteria. So this is an example of that. The HMO on the left is the first introduced undigested type, and these are the 5 components that we talked about, fructose being on top, and that's the one that's cut off in this example by infantas, and then after that's cut off, structurally other enzymes from other bacteria or even other parts of our own cells are able to have access to these nutrients and break it down more and benefit from them. But if the initial breakdown by the bacteria, by the enzyme within the bacteria in our neonatal microbiome wouldn't be present, that entire downward access of the nutrients wouldn't be able to be utilized. All right, so we spoke about a little about why HMO is important. There's, as I mentioned before, dozens of different mixtures of possible HMOs. From this, only a certain type of bacteria can be, a balance between the bacteria that are in our gut can be obtained after this HMO is broken down. If the infant isn't exposed to the HMO, or the infant doesn't have the adequate bacteria to adequately break down this nutrient, then the entire gut microbiome shifts to something different. This is important to know because initially, for example, there were different formula companies that tried to introduce complex oligosaccharides or sugars into formula, and what this did initially was led to a colonization of certain bacteria that weren't favorable, or bacteria that didn't promote, not that were harmful, but didn't promote the protective factors that were initially envisioned. Because when you just give one type of nutrient, it throws off the balance, allowing that one bacteria that might or might not have the downhill benefits for the other bacteria or the own host to be present. So it's important to know that even though in formula HMOs are present, it can have this benefit or this effect where one specific type of bacteria is promoted over others, although they've gotten better over time. And that's just why I emphasized in the last point how galacto-oligosaccharides and fructo-oligosaccharides were initially introduced and had this benefit. All right, so other properties of HMOs. First one is they're bacteriostatic. An example of this is that it prevents or stops the growth of group B strep when HMOs are present. And they can also have not necessarily bacteriostatic effects on Candida, because obviously it's not a bacteria. It doesn't stop their growth, but it does change their morphology or their hyphae, and it prevents their colonization or their ability to colonize in a specific location, such as the urinary tract. Other properties is they have anti-adhesive properties, which can block pathogen attachment. An example of this would be HMOs have been shown in mice studies to reduce the colonization of Campylobacter jejuni in mice studies, and they've had similar effects with Entomoeba histolytica, which is a protozoal parasite. So it's in all three of these examples with the Candida, with Campylobacter, and with the Entomoeba, we see protective factors beyond just against pathogenic bacteria. And then finally, HMOs can have effects in other organs, not just the gut. And the reason for that is even though it's in a much smaller quantity, HMOs are present in other parts, in other organ systems like the respiratory tract, skin, and the urinary tract system. In the urinary tract system, for example, they have been shown in infants to show, has been shown that the urine can contain some HMOs in formula-fed children. And these can have protective factors with anti-adhesive properties, their bacteriostatic properties that protect against things like UTIs. This is especially important in premature infants where a UTI is a serious concern that can lead to other things like sepsis. So who are the key players? I'm going to talk briefly about some of the other bacteria besides Bifidobacterium present in the neonatal gut. So other bacteria that are present there naturally are proteobacteria and actinobacteria, and they become, as time passes by, these changes into firmicutes and Bacteroides. This is true for full-term infants. Preterm infants will have a different set of bacteria initially present. But as we talked about earlier, Bifidobacterium are the one that are more present in the gut of breastfed infants, while Enterobacteriaceae are the ones that are present in formula-fed infants. This is a graph that shows us the different types of bacteria that are normally found in the neonatal gut. They can be divided into 6 total categories, or 6 main types. So establishment of the early microbiome. The early microbiome that its establishment is important because it provides, it allows for the adequate maturation of the gut. Some of the ways it does is by stimulating not only the gut but also other organ systems. This includes the endocrine system, the nervous system, that we'll talk about later on. So there have been multiple studies that show the effect of how important this early recolonization is. For example, there are mice studies these mice that are made that are born completely germ-free. And if they introduce a gut microbiome into this mice study later on in their, after they're born, they eventually will develop a mature gut compared to other mice of their same age. But they won't benefit from having, or the protective factors of the gut microbiome, and will have the things that went wrong but for not having any bacteria present will still be there. An example of this is that in these serum germ-free mice, the immune cells of the mucosa were noted to be very low. In these germ-free mice, if the if a desired gut microbiome was introduced very, very early on, this changed. The mucosa in there was then noted to be normal. But if the same microbiome was then inserted at a later time point, the benefit of having a normal mucosa was not shown, even though by the end of it, both types of mice have the same microbiome present. So it's real important to understand that the early establishment of the gut microbiome is really important in restoring the altered phenotypes. And this is just a schematic of that. This helps us visually see how having good microbiome early on can set you up for a healthy status versus having gut abnormal or a dysbiosis of the gut microbiome early on can set you up for infection, neck, atopy, diabetes, IBD, and IBS. We'll talk about those in a second. The only other point that I made sure that I want to write here is that if we look at two infants, by the time they're 2 or 3 years of age, just like the mice studies, even though they have the same or very similar microbiomes, their health outcomes could be vastly different. All right, so special shout out to bifidobacteria. I've just talked about it so much, and there's a picture of what it looks like there. So Bifidobacterium, just a little bit of a background ecologically from it. It's noted to be clustered in 7 different ecological niches, such as the intestinal tract of humans, non-human animals, birds, social insects, wastewater, and human blood or the oral cavity. These ecological niches appear to be random, but if we look at them a little more closely, they're noted to be in host of social animals with offspring that enjoy paternal care for longer periods of their infancy compared to offspring of mammals or birds that don't, or even social insects. So it's important to know that this is a bacteria that's been found in really social animals just like us. It's one of the some of the components of it that make it special are EPSs. These include things like the fimbriae or the pili, or so the secretion of serine protease inhibitors, which are involved in the signaling of host for the host to mature or allow certain other types of bacteria to be present. So this is just one of the components of the bacteria that allow it to communicate well with the host that it's in. Some other things that besides communication or the types of communication that are involved with this type of bacteria are pro-inflammatory responses and the development of the immunological programming. That's what we're going to talk about here. So, and I want to include Bacteroides also because it has some similar effects in it, although not all the benefits of having bifidobacterium in your neonatal microbiome. So some of the properties that it has anti-inflammatory properties, and this is done by the suppression of the IL-17 mediated response. So it can help decrease the gut inflammation present at the time if the bacteria is present. It can direct an immune response by the ability to help the GI tract mature. And it also has factors that do a little bit of the opposite of the anti-inflammatory response. It actually, well, we'll talk about that in a second. Sorry, I skipped ahead. So it also has another protective factor by allowing tight junctions to be further enhanced, which increases the gut barrier function. So we have anti-inflammatory process, we have direct immune response with some pro-inflammatory responses that helps the maturation of the gut, as well as the promotion of a tight junction, which helps the gut barrier function. So what do these protective factors do long term? Well, they're going to help protect against certain negative long-term health outcomes. I want to emphasize neck for a second because although there is not a clear reason for neck to occur, or necrotitis and enterocolitis, there is a lot of evidence that have repeatedly showed the identification of proteobacteria and Clostridium perfringens within the neonatal gut of infants that are affected by this. And then the opposite is true also, where in the same gut microbiomes, there's ongoing research where they're looking to see if bifidobacterium has a protective factor against it. And that's because of some of the ways that it is believed for NEC to be developed. Just very similar case with neonatal sepsis. There's been studies that show that there's a lower bacterial diversity in these patients with reduced levels specifically of bifidobacterium and Bacteroides. In NEC, some of the things that affect the infant are more microbial dysbiosis. These can happen because of the introduction to antibiotic exposure, acid-reducing agents, immature intestinal barrier. This means the immature barrier is a lot more leaky. There's increased permeability because the tight junctions aren't as well developed. And then there's an immature gut response. Because of the immature gut, there's an exaggerated inflammatory response. When we talked about bifidobacteriums, it addresses a lot of these things, promotes a healthy microbiome establishment. It helps support tight junctions, which gives more integrity to the gut. And then it also helps modulate accordingly with pro-inflammatory and anti-inflammatory responses to the gut for its maturation. So it makes sense how all those protective factors of the bifidobacterium can help protect against NEC, but there's still, again, ongoing research as to what the case is in that. Other things other long-term health outcomes that have been associated with the neonatal gut microbiome, allergy, including atopic eczema and asthma. So it's been noted that having an inappropriate development of the gut microbiome does give you increased risk for these things. When we look at the levels of Clostridia, when looking at the microbiome, there are noted to have increased levels in Clostridia while decreased levels in bifidobacteria. This is initially early on, which then leads to the increased risk to develop eczema at age 2 and asthma by age 4. When the infant microbiome is exposed to antibiotics, this is an example of dysbiosis, and it can set you up for these negative health outcomes later on. So metabolic disorders are are also another concern for the neonatal gut microbiome. Being abnormal early on or dysbiosis. So an example of that would be looking at the microbiome not only of the infants but also of the mothers early on, and then the negative health outcome that could lead to, specifically looking at obesity-related disorders. So one study looking at bifidobacteria populations in patients that were 6 to 12 months of age noted that if these bacteria were normal, there was a correlation with a patient being overweight by age 7, and very similar with Bacteroides. Looking at levels at age 1, if they were significantly lower, there was an associated with a higher BMI at 1 and at 10 years of age. Other chronic disorders, the other chronic disorder I want to emphasize is type 1 diabetes, looking at endocrine disorders, as well as IBD and IBS. So there have been many studies looking at the gut microbiome association with type 1 diabetes, and many have found that there is a lower diversity in the gut microbiome in these patients that are found to have type 1 diabetes. Specifically, the ratios with firmicutes and Bacteroides are the ones that are thrown off, and also a decrease in abundance of pyruvate-producing bacteria. This is the firmicutes, Prazotuosi, saying that a little bit wrong. But having a decrease in this kind of bacteria has been associated with type 1 diabetes, and the opposite has also been shown. There has been shown to have an increase in this type of bacteria in non-diabetic children. So finally, the things that are emphasized in our talk was the importance of the dogma that the sterile gut is something that's used as a central dogma to study the gut microbiome, because it allows us to understand how the colonization of the gut microbiome is obtained and how important that is early on. Although I did talk about that there's new studies or new research ongoing that tries to prove that the gut microbiome colonization actually happens even before birth. either way, though, with either study, the development of the early gut is very important, and it's modulated by things like HMOs that are found in breast milk, and we talked at length about how this helps promote the colonization of bacteria that have protective factors in our body. And then we talked about how there are some factors that will modulate the microbiome. These include just breastfeeding state, genetics, maternal diet, geography, but in a premature infant, I do emphasize that the gestational age is the one that is most important. We talked about dysbiosis and how this can affect many, can be the cause of, can have causality with many intestinal diseases, including neck, as well as diseases later on, like IBD, type 1 diabetes, IBS, asthma, eczema, and obesity. The next part of research in this topic is to figure out ways to appropriately evaluate the composition of the microbiome and identify shifts. We talked about in the very early part of the talk about new research or new ways with shotgun metagenomics that is trying to do this, but there are some drawbacks to it currently, specifically cost. And then the next part would be to identify important biomarkers to help understand if there is a dysbiosis in the neonatal gut microbiome, in an effort to develop prophylactic approaches as well as address imbalances before they create these disease states. So let's go back and look at the question. We talked about the 28-weeker that's in the NICU on CPAP with the mom and the maternal history that was initially presented. So out of these modes, or out of these factors that could potentially affect the establishment of a neonatal microbiome, gestational age at delivery is the one that will more heavily impact the type of microbiome that's established. These are my references. This is the last slide. Any questions? Yes. Thank you.
I was just wondering, a lot of times parents will ask me, what formula should I be getting for my child? And I'll tell them they're basically all the same. There's a lot of marketing surrounding different formulas, but because it's really hard to pinpoint research that would make me recommend one formula on top of another. I know there are generic formulas with HMOs as well as some name brand formulas.
After this, I would. I think it just from the research that I did for the presentation and the research I ran into, initially, that's why I gave the historical context of it wasn't HMOs that were initially introduced, it was just complex sugars, and how that led to the development of a gut microbiome that didn't have the protective factors. But HMOs specifically are the ones that are introduced in breast milk, even though they're not as diverse as the ones in breast milk, are the ones in formula, are the ones that are able to still do promote or try to promote the bifidobacterium, and we saw the different protective factors that has on our body. But it just doesn't do it to the degree that breast milk does, and it doesn't modulate or change over time with the developing infant. I feel like I ignored you guys, but it was just because this wall was there and this does not move. Do you guys have any questions? Or another question here?
Have you come across any new research about pros or cons of probiotics in our patients?
There is in older kids, because the mature microbiome is established from some of the different papers I read by age 2 and 3. By age 2 and 3, the gut microbiome of different kids is about the same. So it doesn't look like it hurts them. And then there are protective things against, there are benefits with it. One of the things in our hospital that we use a lot is when kids have acute gastroenteritis, and it helps reestablish a healthy gut microbiome with these probiotics. In neonates, it's a little more challenging. Our kids in the NICU with premature infants and neonates, a little more challenging to answer that question because the introduction of probiotics or bacteria basically into the gut can have different effects depending on their age, what other comorbidities they have, inflammatory status in their gut, what they're feeding, what they're currently feeding, if they have been exposed to NEC or haven't been exposed to NEC, or they're at risk for it. Their heart plays a big role into it because that allows the oxygenation of their gut. So there's different things, and because of this, there's not a clear consensus on giving probiotics, whether or not they 100% will, for example, help reduce the risk of NEC. There are some NICUs that, to all their premature infants, give probiotics. Dr. Adcock's not here, but I found out that University of Kentucky NICU does do that. They give probiotics to their NICU infants, while others don't.
Stay tuned.
There we go.
So probably in April, we're going to start giving a product called Vivo, which is Bifidobacteria infantis. It's a liquid form that you can give through an NG tube to our preterm infants, realizing that encouraging breastfeeding is probably going to be more important than doing something like that. But there is some encouraging evidence that can help. There's always concern. Bringing bacteria into a NICU is not something we take lightly. There's definitely infants with depressed immune systems. There are case reports of having a clear sepsis picture with the blood culture growing only of bacteria that we've introduced. So that's scary. We're going to take some steps to do it properly, but there are more and more NICUs doing that for the preterm babies.
And as I was going through this also, one of the things that came to my mind was the potential benefit of having a breast milk bank because of the HMOs that our patients could potentially be exposed to if that were something to be established. Any other questions? All right.
Stay tuned for that too, I hope.
There you go.